Thank you very much. Before we get started, I would like to point out that we have our sign language interpreter here with us today. Her name is Mindy LaFollette. Mindy, thank you so much for being here. If you would like to know how to pin the video, please look in the chat box. Alexa, you ready to start the presentation?
Yeah, did you want me to share the slides or do we need to? Or do you want
Alexa
to?
will pull it up for us.
Yeah, absolutely.
Perfect. Thank you, Alexa. Okay, welcome everyone to our, whoops. There we go. Welcome everyone to the Foundations of Global Health. Alexa, could you go to the next slide? Thank you. Okay, so the goal of our Foundations of Global Health, it is designed to connect residents, students, learners, and faculty to leaders in global health. This series is created to support the development of global health professionals, giving participants inspiration as well as shaping attitudes around global health so that we at KUMC are trendsetters who move beyond the us versus them or have-nots mentality to a platform of equality and multirism, which garners true collaboration and global health exchange for everyone's equal benefit. The goal of this series is also to inform participants about the fields of global health in its entirety, and also to include global health research, philosophy, approaches, attitudes, and the varied efforts in areas of health disparities, health inequalities, and community health. We have a few upcoming events. These are not all inclusive. We have several more next year, but the next 4 events in the series, the first one is, or the next one rather, is on November 18th by Dr. Mendez, and that will be at 5:30 p.m. We have Dr. Alan Greiner, who will give a presentation on December 1st. He will present on working in community settings and vulnerable population groups. We also have Dr. Nathan Barr, who will give a presentation on ID Global Health Research. That will be on Monday, January 25th at 12. And we have Dr. Halsey, who will give an insider's secret to starting a career in global health, and that will be on Monday, February 8th at 12 p.m. So without further ado, it is my pleasure to introduce Dr. Timothy Ryan Smith. Dr. Timothy Ryan Smith is an associate professor of pediatrics at the University of Kansas. After working in training experiences in Bolivia, Honduras, and South Korea, Dr. Smith has worked on undergraduate and graduate programs in global health, as well as serving as a primary care provider for refugees and the Latinx families. Welcome.
Thanks a lot, Alexa. Thanks a lot, Christine, and everyone at the Office of International Programs. As a medical student here, I am so impressed and excited about the incredible work that's been done in the Office of International Programs, and to see the great work that was done when I was a medical student has just been turned on its head and progressed incredibly so. So the group today, I think, is a good size to have some discussions. I'm going to kind of talk about my personal experience, how I ended up heading to medical school, heading through training, joining the faculty here at KU, and along the way, how global health has kind of shaped and been an important part of my daily practice, and still something as we talk about practice and medicine, and we're all kind of navigating and figuring out what we're going to do with our lives and what's next. I still have that as I still try to kind of find how different experiences in global health are going to guide my career. But I think we have people across the levels of training and career right now that can kind of speak to how global health has been a part of their experiences. And hopefully I can go through a few of these slides and we can spend a little bit of time having a conversation about how do we get engaged, how do we really experience meaning in the global health experiences that we have. So next slide. So I think, again, like when I think about global health, and I appreciate the slide by our Office of International Programs, again, pointing to the importance of connecting with other populations and examining and trying to address inequities within our health system and health systems across the globe, and just how a myriad of different health, social, and policy factors all kind of meet together to have an impact. And really, like, I think I don't think I'm alone in being particularly attracted to global health due to its novelty, its real priority in trying to find solutions, trying to improve outcomes for vulnerable populations. Next slide. So I'll hope not to get too winded, but I think getting a little bit of sense of my trajectory heading into my medical studies, through my training in medical studies, and then after joining the faculty, me kind of help push some concept of how some people can kind of experience global health as a kind of full-time job, as a training experience, as something that is done stateside, as you're practicing clinician here in the United States. So graduated from college in 2000, taught high school for a year, became a little restless, decided to move to Honduras despite not speaking any Spanish, which was probably not wildly wise, but I had a friend of a friend who had a contact at a Jesuit Catholic parish in Honduras, and I spent some time chatting with one of the priests, and I got that first sense of community engagement and the ability that, like, small community efforts can really make a ripple, not just on health, but the entirety of lives in certain communities. So I lived in Honduras for about 9 months. The types of work that I was involved in was organizing communities around 2 gravity-fed potable water projects, 2 community gardens. There was also a number of people who had worked on general health education, women's health, women organizations. So this was an interesting and a few different educational efforts, some of which was related to specific technical training around auto repair and carpentry. And so it was an exciting time to see what the grassroots could really accomplish, and what just getting out into these communities, which were pretty isolated. I took a lot of donkey rides. I remember writing about that within my personal statement. But the idea of being able to connect with people and having those people working together to improve their health, to improve their lives, is one of those things that I think, like, still shapes me quite a bit to this day. So after that experience, I came back to Kansas City. I was a point of health contact because I was also a MPH student at the time, and had an interest in attending medical school, but hadn't yet applied. I was kind of understanding within a healthcare system what I wanted to do, where I wanted to head. And so I worked in job counseling and as a caseworker for newly arrived refugees in Kansas City. And so I was at Catholic Charities, and I'll kind of go more into the refugee kind of demography in a later slide. But I was there for about a year, and I felt pretty lucky to get a chance to work with some medical students who were rotating through the agency. And I think, again, it only further captured like the need for healthcare providers, community advocates that are really interested in navigating a wildly complex health system for our refugee community members. Following my time at Catholic Charities, I was accepted into medical school, wanted to have another kind of experience. I'm probably not alone for those that are in global health. Traveling, seeing new things, trying new foods is some part of the draw. It's not the only thing, but it is one of those things that's it's always fun to have a new adventure. So I spent about 5 months before starting medical school in Korea and traveling around East Asia. Went to medical school. I was very involved in JDOC. I had worked with my time in Honduras and a little bit of study outside. I had developed my language skills significantly and started to interpret Spanish at JDOC. Spent some time in the JDOC executive board and pretty engaged in clinical care there through my 4 years. I will say in my 4th year, I was very excited to go to a South American country. I was hoping to go to Paraguay with my February 4th year elective. I'm probably not the only medical student that procrastinates a fair amount and occasionally gets behind on the things that they need to do. And I didn't get a chance to have that experience in Paraguay, but I did end up going with a close friend and classmate of mine to South Africa. I had a really incredible experience seeing a vulnerable community, a rural community, in one that actually had a fair amount of health infrastructure, a hospital that had physicians from kind of all over the world that helped staff, as well as junior physicians from South Africa, many of which were participating in the required rural training. But I had a clinical exposure to multi-drug resistant tuberculosis, to HIV care, and a number of infectious diseases that I had very little exposure to before I arrived in South Africa. And that included a pretty significant measles outbreak. And so before I'd even arrived in residency, I'd seen about a half dozen cases of measles, which for a lot of providers currently in practice, it's been too long since we've had a lot of cases in the States, and many people haven't seen any cases at all. So I attended residency in categorical pediatrics at the University of Minnesota. Minnesota was a particular draw to me. First of all, the university has a long tradition in global health. They were, I think, the first or second residency program to provide a global health track. And that's available in family medicine, internal medicine, and pediatrics. And there was all this infrastructure and opportunity within the university, but additionally, like Minneapolis and St. Paul is a very diverse community that has a number of refugee and national populations that have kind of economies of scale. So you have the Somali population, more largely concentrated in the city of Minneapolis, which numbers about 80,000 people, at par with larger minority communities in our metropolitan area. There is a similar percentage of Hmong individuals in St. Paul, and there's a growing populations of well over 10,000 Liberians in the northwest suburbs of Minneapolis. And so it's been a place that has been a leader in refugee resettlement over time, and it's built these economies of scale. There's all of these organizations that can support the members of their communities, and all of these leaders, political, health, and the like, that to be around to learn from during my residency, I thought was incredibly valuable. One of those things in being in a global health track, I had a lot of formal education. Both particular to the tract and in our the entirety of our residency, but it provided us the opportunity to do some research and to have more time abroad during our residency training. So unlike a lot of programs that will allow up to 1 month so-called unfunded, where you aren't necessarily providing clinical services and generating money for the hospital, they provided the opportunity to do up to 3 months of unfunded service. And so I ended up spending 2 months in Bolivia and another month of research. And so that's another little thing once we get to kind of the details. When you're looking at programs, think about like how much time you want to spend away, and which programs provide you more than a month to get a chance to have more in-depth experiences. I do have to say, for a place like Bolivia, it was really nice to have those 2 months of being able to see patients and become acclimated with a very complex health system. And then after graduating from residency in 2013, I joined the faculty. My duties within global health have changed quite a bit over time. In the first few years, I spent a significant amount of time as our KU director for the Joint Children's Mercy KU Global Health Track. And so between the two programs, about a third of the residents elected to participate in the Global Health Track. And the majority of those that did ended up doing 1 month abroad, usually in the fall or winter of their final year of residency, their third year of residency. I will say I was very excited and touched to be engaged by Dr. Archie Headings in orthopedics, who has been working with the Office of International Programs to broadly expand the partnerships that the university has at different clinical sites around the world. And so Dr. Headings has really done exceptional work in Eastern Romania. And I got a chance to go with him and his team 2 years ago. That's kind of started some relationships, and we participated in some research now that is going up for publication, and some other smaller projects that are being presented as posters. So those are a few other things along with that, and getting involved in one of my professional societies, the American Pediatric Association. I co-chair their global health steering committee, and it's another opportunity to kind of build educational programming for residents, fellows, and for faculty. And we kind of really focus a lot on international partnerships and how do different institutions kind of help facilitate that. So that's a little bit about me. Can you get the next slide, please? So I think, again, when we think about global health, I can't help but kind of characterize in the same way that I do my other efforts, and this idea of looking at, do I want to be providing clinical services? Is it really a perspective of education, educating other clinicians, educating actual patients, educating community health workers or other kind of staff to go out and provide service? And again, there is lots of opportunities to research. I think it's been exciting. Just within like the 7 years I've been here on faculty, I've seen a lot more work on international health research here at our university. And I think everything that's been shown to me with the efforts that are made is that's just going to continue to kind of move forward. So next slide. One thing that throughout the whole of my international health experiences, I've always been kind of drawn to innovations in low resource areas and how they have ultimately kind of driven new programs across the world. And I think that there's probably no better example than community health workers, which I do a fair amount of community health work in my practice right now. And that's very fashionable now to talk about community health workers, but it's interesting to know that Promotores de Salud or so many different programs across the world. A lot of this kind of starting in South America, Brazil, and Mexico 20, 30 plus years ago. And it's really an established like model to providing care, which is providing targeted education on particular health concerns to well-respected members in the community and send them out in the community. There's an issue in general within global health is healthcare staffing and the number of physicians, nurses, and more technically trained staff. And so to be able to deal with really incredible staffing challenges across the globe, community health workers has been a model that I think like has been really exciting, has achieved a lot. And now I think we are beginning to understand that there's so many different vulnerable populations that we work with that really struggle deeply to touch our health system to access care like they need to. And community health workers are one of those ways to kind of help facilitate that. The other thing is in the developing world, mobile technology has been such an important thing. And again, with certain communities that may have limited access to electricity, limited access to more traditional utilities, mobile technology, cell phones really have provided a huge benefit. And so like it kind of started with mobile banking, and now there's no shortage of different health apps and innovations that have come along with cell phones to reach areas that are really pretty isolated and without any cells, without much electricity and with much less infrastructure than what you'll see. I know Dr. Sarah Kessler has worked a lot on some of these innovations in Southern Africa and monitoring HIV risk and prophylaxis. And so again, like that's another spot where global health, especially healthcare systems in lower income countries, are kind of leading innovation. And it's interesting to see like in lower resource countries, innovations in just product design and engineering is really moving things forward. I know for the group that I worked with in our Academic Pediatric Association, we invited a faculty from southern India that made a incubator out of cardboard. You collaborate with an American university, but the idea of these incubators in this States and throughout Europe and other places can run into the tens of thousands of dollars. And to have an incubator disposable with a limited carbon footprint that can cost as little as $40 or $50 really kind of profoundly shows how you can change the way they provide care and expand access without necessarily investing huge amounts of funds. Next slide. So again, to kind of have a brief overview of the different opportunities that are out there, I think language study is one of those things that is always worth prioritizing. I valued the formal time that I had in Bolivia to do a little bit of a Spanish language study. But I see a lot of medical students, I see a lot of residents that have had some training in Spanish, maybe French, Portuguese, any number of different languages, and are just scared to use that. And the idea is like having some time to do some targeted language studies, to have maybe an immersion opportunity, but to take that time and to take that step out and try to make a little bit of a fool of yourself as you're navigating through speaking another language is that first thing that you need to do. And I know in my practice it is exceedingly valuable because about 60% of my patients don't speak English as a primary language. About 40 to 50% of my patients speak Spanish, for which I have a growing amount of proficiency. I will never call myself fluent by any means, but that's been an important thing, and it's added a lot of value into my own practice, being able to connect with my Spanish-speaking patients in Spanish, and trying to pass it on to my girls, my infant girls, and again, my partner also. So another opportunity, I think I see Alex on there, who I know is really involved in the KUMCIO, but there is this idea of short-term trips. I know the medical school has often had two trips to different areas of Central America. And again, like it's good ways to collaborate and meet with colleagues. The one caveat that I will say, I think it's so critical to make sure that you have strong ties to health systems in the areas that you're visiting. And I think like that's another thing that just within the last 20 or 30 years, there's been a lot more attention to. And so it's nice having heart to heart, I'm blanking on the name of it, but the Medical Missions Society in our community that has now spent many decades developing these relationships at different communities that they visit. There's also this idea of month-long, or in certain cases, multiple month-long rotations. When you get a chance, I would really encourage that. I think it's challenging. It forces you to be humble, forces you to look at things very differently. But every time that I've got a chance to spend any amount of time abroad, but specifically more than a few weeks in some place doing clinical or education type work, it's been incredibly helpful. Research, again, I think that's growing. I think there's more and more opportunity. And I think Alexa, Christine, and Kimberly are really to be thanked for that because the Office of International Programs here has really understood that as a university, like we teach, we learn, we study, and so having a really involved research program globally is very important. I don't know of any medical schools that necessarily have dedicated global health tracks, but I will say across the residency programs, there are global health tracks. And so I think that it is probably most established and broadest in the primary care subspecialties, internal medicine, family medicine, pediatrics, but there are surgical global health tracks and as to my knowledge, other subspecialty global health tracks. And the idea is that is typically you have a set curriculum over a particular amount of time in your training program. It's built in with mentorship and real milestones in the course of the track. And then usually a nearing capstone is an opportunity to spend some time clinically abroad. And I know that that's one of those things we're learning more and more, at least in pediatric trainees, like about 70% of trainees have an interest in global health experiences, want to have global health tracks available. And I think regardless of on the medical side, what specialties you're getting into, that's going to be more available. And for other staff roles, for other career fields, whether it be allied health and nursing, I'm not as familiar with the programs, but I know that there's growing programming, and I suspect somewhere within the country tracks that are kind of analogous to what we see in the residency training programs. And then I think for those that are even further committed to academic work in global health or just clinical service abroad, it's really worth looking into global health fellowship programs. I know at least in pediatrics, there is the Baylor program, and Baylor's always been a leader of pediatric HIV care throughout Eastern Africa. Children's Hospital Philadelphia has two clinical sites, one in Africa, one in the Caribbean, UCSF, and there's only going to continue to be a growing number. I think there's maybe 10 or so pediatric global health fellowship programs right now, and for that to be doubled in the next 10 years wouldn't surprise me. And again, I think that is a great opportunity for those that really see global health, either stateside or internationally, as a big part of their career. Next slide, please. So here's some of the different places where you can kind of enter into work. There's global clinical practice. It is pretty variable across the world how different US clinical skills correlate into different national systems. I know that Mexico, just like you do in the States, needing to complete a residency in the United States or Canada to provide care, to earn an income from medicine within Mexico, you need to have Mexican residency training. There are certain countries like South Africa with special permission and low resource areas with support of your National Medical Society can provide clinical care, but it's really it's variable from community to community, country to country, as to whether or not your clinical skills are directly applicable in different countries. But even if it is more than just filling out a bunch of papers, there's generally always a path to providing clinical services in another country if that's really the way that you want to go. I know there are some opportunities, but incredibly strong competition to work for international organizations, whether it be UNICEF or WHO or large international NGOs like Save the Children, Gates Foundation. Those are great opportunities. Those are all like positions that fellowship programs and a strong research background can certainly provide you an advantage. I will say, like, I had my work at Catholic Charities Refugee Services and wanted to do something at NGOs, international organizations, and didn't have a lot of success finding work. I also didn't have a whole lot on my CV resume. And that was one of those things that had me head into the School of Medicine. But that's one of those ways that we can go. I think, again, there, within academic medicine, there is an incredible number of points of collaboration, some of which we can do completely stateside, especially as like our telehealth, teleeducation services expand. That's definitely one way to go about it, and the way that I have largely kind of proceeded over the last few years. And again, these ideas of short-term, medium-term, long-term visits to areas outside of our own borders. Next slide, please. So I think, again, I have a practice, again, that is majority immigrant, but I think it's important to realize that my practice is kind of a majority immigrant by design, but I think it's important to realize that we are a rapidly changing population. We are becoming more diverse. We are seeing more and more people of broad national origin from Africa, from Latin America, and with that come particular challenges. And I think understanding culturally competent care and understanding how demographics are clearly shifting is very important. We're getting younger, we're getting browner. So next slide, please. So you can see I'm always kind of surprised when I go to national conferences. People are like, do you guys have Latinos in Kansas? They're, especially on the either coast, there is a lot of misunderstanding as to the vibrant, diverse communities that we live within. And so I think the left schematic here is an important one that, again, speaks to the fact Kansas City, Kansas, where our medical center, our university resides, as a majority minority community, a community in which Latinx patients that identify as Hispanic are quickly becoming the plurality of our population. And you can see here within Wyandotte County, the quarter of patients that speak predominantly Spanish. And then you can also see a not small percentage, 15 or 10 to 15% of people in our community that speak neither Spanish nor English as their primary language. And so again, like understanding the real diversity that we have and understanding how it affects our care is kind of critical. Next slide, please. I'm meandering off longer than I thought, so I'll try to move through these next few slides a little quicker. Wanted to provide a little context for refugee care. We have a very large refugee patient population in our primary care practices. I think it's at our location. It's the history that we've had with these refugee populations. There's people like Dr. Lemaster that speak Nepalese and has a clinical practice that's almost entirely Nepalese speaking patients. Refugees are those that cross national borders for a well-founded fear of persecution. The U.S. Refugee Resettlement Program was started in the 1970s to resettle designated Vietnamese, Laotians, and other Southeast Asians after and around the time of the Vietnam War. The numbers have been pretty variable. and peaking out at about 70,000 individuals resettled annually. It's important to realize that it's always shifting, just as areas of conflict are changing very rapidly. Where refugees are resettled to is changing quite a bit. And refugees or asylees, the difference between an asylee is that they petition for status at their country of asylum. So someone that comes to the U.S. and wants to be integrated into the U.S. will petition for asylum, while a refugee will cross a national border, petition for refugee status, and then if they are resettled as a refugee, they'll be resettled to entirely different countries. So it's kind of they're similar in how they function, but where they actually end up is the difference between asylees and refugees. But those that come to that are recognized as asylees and refugees, they come with some access to services that not all immigrants enjoy. They get some length of time with non-means tested Medicaid, and they have a little bit of support from their social service agencies as they initially become adapted. But still, accessing healthcare, navigating a health system is incredibly complex, especially for numerous refugee groups that have little exposure to Western medical systems, even Western concepts of medicine before arrival here in the US. And I thought I'll tell this story, which I think kind of shaped my real interest in refugee health, and it was well before I entered medicine. But this is when I was working as a refugee social worker, and we had a group of KU medical students talk about tuberculosis, and we have a handful. We have the near majority of active TB cases in the county each year come from recently arrived refugees, and they have a very, very robust screening program in refugees. And you'll see the refugees getting off the plane, and they all have the same OIM sweatshirt, and they have a big giant plastic bag with x-rays and some paper charts. But it's interesting, like the presence of TB, the presence of even microbiologic disease doesn't make a lot of sense. So the medical students were kind of going through the presentation about TB treatment and epidemiology, all those things. And one of the people in the crowd asked the question, so why is it that we left Africa and we got on a plane and we came to the US and all of a sudden we had tuberculosis? And so the idea that like just carrying something without being seen, without being symptomatic, that was something that was just beyond what these people, that the refugees are recently resettled, really understood. So there's just no shortage of the challenges that we have to getting these patients into care and getting them seen appropriately. Next slide, please. Again, I can't speak enough. I can't throw enough praises at the Office of International Programs for growing curriculum, for having series like this, for building partnerships. I know from all my other partners, other institutions, this is agonizingly rigorous work, but over time, as we have institutional commitment, these partnerships do become kind of established. And again, more and more places to go, more externships, more research is coming along on a regular basis. Next slide, please. So again, a few little words of wisdom. If you do plan on going abroad, plan early, be flexible. If anyone knows anything about COVID, flexibility is our life, and it's going to be our life for a little bit. But when we get back to more of it, continue that planning, continue that vigilance. whatever that language that you're training in or interest in, think about more formal structures. We have medical Spanish electives. Most residencies will have language electives and training. Find a mentor, find someone that you trust that kind of sees eye to eye with you in global health, and try to really lean on that person to help you build a plan going forward in your career. Always, like, as you cultivate those relationships related to global health, stay in touch, keep active, be humble, laugh. I will say, like, spending long periods of time away from family, away from friends, in very new environments. If you're not willing to be open to new things, be flexible, laugh at things that are kind of a little wonky, it can kind of stress you a little bit. And then wherever you go, like, whether it's the community health workers in Bolivia, whether it's the incredible testing and kind of public health infrastructure they have in South Africa, always think about, in Romania, the incredible access that they had to subspecialists. Start out by always trying to focus on the strengths of whatever community that you're working with. Then, next slide. So again, I rambled on a lot more than I thought, but here are some of the questions that I thought about. Anyone can kind of take a jump at these, but again, like, I'm just kind of curious to know where other people are with global health. What do they want to do in global health? How have their experiences right now kind of shaped them?
Thank you very, very much, Dr. Smith, for that wonderful and informative presentation. I invite our students at this time to please take your mic off mute and ask away.
Since I know Alex and I don't see anyone jumping up at it, like, you're on, like, do you want to talk about your experiences with KUMCIO, like what challenges it is for doing these short-term trips, how you think
Yeah,
it
well,
shaped you?
yeah. Well, actually, I'm not involved in KUMCIO. I did more work with the Partners in Health chapter at KUMC. So more like education and awareness of global health issues, which was really important to me as a medical student, since I don't have, like my medical degree yet. I really wanted to focus on like my local community and kind of just like building awareness of global health issues. So I kind of made that my focus of medical school. But now, since I'm applying to residency, and actually I have an interview for the PEDS program at Minnesota tomorrow.
Nice,
So that's
good luck.
exciting. Yeah, I didn't realize that you went
tell
there.
everyone hi for me.
Yeah, I will.
There's a lot of overlap still.
Yeah, and I was definitely interested in that program because of their like groundbreaking global health. Like it was very apparent in like some like open house stuff that they did earlier that they're like really one of the kind of leaders in global health. So yeah, like looking for programs that have more like global health training and like advocacy work, both like, I mean, worldwide. That's kind of my focus now, but it's helpful to hear like some of the stuff afterward. Like right now it seems like, nothing's gonna be after residency, but it definitely is like something I need to keep thinking about. And I don't necessarily know how global health will be incorporated into my career, but I mean, there's like no way it won't be in some way, because there are endless ways to be involved in global health, both like local, global, and like, across the globe.
Yeah, you can't escape it if you try. I know we have to have some other global health experiences out amongst the attendees. Someone just wants to talk about what they've done, how that kind of provided some meaning, what they see as aspirations for global health in their career. We had a chat question as far as a global health track for social workers here at KU. I would check with your particular school leadership to see what sort of global opportunities are available. I will say when it comes to social work and care coordination, like the value, especially in like short-term trips, is incredibly valuable. So I mean, reaching out to like Heart to Heart or Medical Mission Society, reaching out to KUMCIO, those are some places for those. In social work or allied health or nursing, I think those are good ways, but I'm not as familiar. Maybe Christine, Alexa, do you know?
Alexa?
I'm not familiar with the social worker curriculum in any way, shape, or form. I don't even know if we have those courses at KU Med. I'm not familiar with those.
Yeah.
At all. The only thing I would tell people is to check out the Global Scholars Distinction Program.
Yeah, and I think if you find anything out, like I imagine Christine, Alexa, you myself would be really interested in knowing what sort of opportunities, and it kind of goes to anyone outside of the School of Medicine. I'm slanted being within the School of Medicine, but for everyone to communicate those resources for the other schools, I think would be fantastic.
Yeah, absolutely. And thank you, Alexa, for bringing up the Global Scholars Distinction Program. So today's presentation is being recorded and does count towards your Global Scholars Distinction Program. I want to be conscientious of your time, Dr. Timothy Ryan Smith, but you mentioned that living in Honduras has really shaped you. I was just curious if you could go perhaps go into a little more depth there, how it has shaped you.
Yeah, so I mean, like, I think again, going back to like the importance of small communities, the priority of community health workers, and again, like we're learning more and more in medicine, and there's more and more attention to social determinants. Now it's not just a fringe of providers and research scientists, but primary insurers like Blue Cross, Blue Shield, Medicare is even encouraging a social determinant screen. And so like what I learned is, again, you see illness, you see health problems that can be addressed, and you see a lack of education, a lack of resources to pay for appropriate health treatments, even the idea of like geographic isolation, the idea of needing routine healthcare and needing to have a 5, 6, 7 hour walk or pack animal transport to go and get the care that you need. I think like we face these exact same obstacles, and it was just a little bit more apparent, but it framed a lot of what I did moving forward in medicine with these social determinants and how they really guide all of our practice within medicine and health.
Thank you very much. And I know you have a 1 o'clock. Are there any other final questions? No? Okay. Thank you very much.
Thanks a lot. I appreciate it. Have a good one.
You too. Thank you.
Bye.
Bye, everyone.